Καλησπέρα σε όλους. Θα ήθελα να ευχαριστήσω την Οργανωτική Επιτροπή για την τιμή της πρόσκλησης σε αυτό το φόρουμ. Να διορθώσω, δεν είμαι διευθύντρια του Imaging, είμαι διευθύντρια στο Fetal Cardiology, αλλά Imager εν γέννη. Θα ήθελα να ζητήσω συγγνώμη γιατί θα δώσω την ομιλία μου στα αγγλικά. Δεν ήμουν προετοιμασμένη για να τη δώσω στα ελληνικά και τώρα που το κατάλαβα έχω πάθει μια μικρή κρίση πανικού. Οπότε θα προσπαθήσω να τη δώσω στα αγγλικά και θα απαντήσω στα ελληνικά ασφαλώς. The topic that I'm going to address today, I have no disclosures, fortunately or unfortunately, but the topic that I'm going to address today is the anomalous origin of the coronary arteries from the aorta. The objectives of my talk are an introduction to the coronary artery anomalies, review the incidence and clinical significance, review the presentation and diagnosis, approach to evaluation and the management of the disease. Coronary artery anomalies are an assorted group of congenital heart disease and have variable pathophysiology, clinical presentation, and implications. We have the normal variations, a single coronary artery, left or right coronary arterial branches arising from the posterior sinus of Valsalva, anomalous left or right from the pulmonary arteries, both coronaries from the pulmonary arteries, LAD or circumflex from the APA or PA branches. Of course, coronary atresia, stenosis or atresia of a coronary ostium, those go with complex congenital heart disease most of the times. Coronary fistula and myocardial bridges. But what we're going to concentrate on today is the abnormal origin of the right or the left coronary artery from inappropriate sinus, AOCA in abbreviation. The types of abnormal coronary origin are mainly two. You can have the the anomalous left coronary artery coming from the right sinus, and it can be a nice origin from that sinus, or it can have an intramural course. And of course, you can have anomalous origin of the right coronary artery from the left sinus, again, with a discrete origin or having an intramural course. It's very useful, especially when we try to talk with our surgeons and our colleagues to kind of like map out where we locate the abnormalous coronary. And you can see, you can see that there are three types of classifying the echocardiographers view, the surgical view, and the radiologist view. Of course, we go with the surgical view because probably those are the people who are going to intervene. So one is the RCA sinus, two is the left, and three is a posterior sinus. And you can see there's A, B, and C. I'm sorry about that. A is closer to the first commissure, B is in the middle of the sinus, and C is closer to the last commissure. And of course, you do it on not only on a left to right basis, but a superior, inferior kind of a base. One, the coronary comes from the sinus, the main sinus. Two, it's above the cusp, but still below the sinotubular junction. Three is it originates from the sinotubular junction, and four, they come above that. Now, why all the fuss? Is this a very common disease? No, the true prevalence is not known, and that's one of the major issues that we have. We do not know the denominator. So the anomalous aortic origin of the left coronary artery is less rare than one of the right. The right coronary artery, in the literature on some papers, it's 6 times more frequent than the left. But the left is the one that has more clinical significance, maybe. The relevance and the importance is that anomalous origin of the coronary artery from the opposite sinus is known to be the second leading cause of sudden death in young athletes. And it's estimated to be responsible for 15 to 20% of sudden cardiac death in this population. It is highest in young individuals, the sudden cardiac death. And the symptoms appear during or following a period of strenuous exertion, particularly in those with interatrial anomalous left coronary. About 50% of the patients have been asymptomatic at the time of diagnosis, and this is the Achilles heel of the whole situation. An increasing number of children and adolescents are being diagnosed with anomalous origin of coronaries, following routine sports screening and evaluation of a murmur or an ECG abnormality. I have to give kudos to the echocardiographic societies in different countries, because they are the ones that implemented in their guidelines of pediatric echoes to include a visualization and imaging of the coronaries. That's, I guess, the most frequent diagnosis of the disease the last 15 years or so. So here I have an example of a patient that comes to the cath lab to have a device closure of a small secundum AST. And the person who reviews the echo, the one who's going to do the TE, has an astute set of eyes and sees something that he doesn't like in the left AV groove. And you can see this is a four-chamber view, and you can see that as we go behind the aorta, you see a coronary continuing in the left AV groove. So the question of an abnormal origin of the circumflex arises. And when the patient underwent the TE, you can see this is the tricuspid valve, this is the aortic root, and you can see the anomalous circumflex coming from the right. And it says that the aortic rim of the atrial septum, so the device closure of this ASD was aborted. And because we shouldn't leave an interventional complaining, we let him cath the patient, diagnostic cath, and you can see here the catheter deep throating the right coronary artery, and you can see the small circumflex coming back behind the aorta and supplying the ventricular groove in the left ventricle. But this is not the classic presentation, as I said. The classic one is exertional chest pain, palpitations, syncope, usually after exercise, as I mentioned before, and sudden cardiac arrest and sudden cardiac death, of course, are favorable outcomes and incidences for our patients. The mechanism is not clear. There might be occlusion or compression of the anomalous coronary, or you can have osteal abnormalities. A lot of those abnormal coronaries have slit-like ostia. And this is associated with myocardial ischemia and, of course, development of ventricular arrhythmia and cardiac arrest. Here's another example of an adolescent that we took care of almost a year ago. This was a patient who liked to vape before PE class. So before the physical gymnastics, he vaped, and then when he started playing, he felt uncomfortable, hot, and went to sit down, but he collapsed. Bystanders showed him having abnormal movements that thought to be seizures. And EMS arrived, a CPR was started. And the defibrillator who was available in the school was activated and delivered 2 shocks. Patient was taken to a nearby ER and then came to our hospital. They faxed the defibrillator tracings, and this patient was in ventricular fibrillation when he was shocked. So a true arrhythmic event. His echocardiogram was brief. It was a Friday afternoon. The function was good. There were no troponin or BMP abnormalities. So a pretty extensive genetic test for arrhythmias was sent, and he was scheduled to have an exercise test on Monday. During his exercise test, there were some T-wave abnormalities in the lower leads. And somebody took another look at his echo. And here you can see a modified view of his RVOT. This is a pulmonary valve, and you can see here a little bit of a blue flow that, again, is not a normal finding in this view. And this is a 2D imaging of his aortic valve. This is the left AV groove, this is the right AV groove, and you can see here his left coronary in cross section. And actually you see it decreasing in caliber as the heart moves. And with a better adjustment of a very savvy sonographer, you could see the left coronary artery coming from the right a little bit higher than the sinotubular junction and going into the left AV groove and bifurcating. And this is the same with color, and you can see here how the left coronary artery, instead of coming from the left cusp, comes more rightwards, almost at the commissure and a little higher. This is the CT of this patient. You can see the abnormal coronary that has an intramural quartz. And you can see here the small caliber of the vessel. And this is a long segment, long view of the coronary, again, narrowing here in caliber and coming from the right. This is a patient that came to us last weekend. Another patient with a history of substance abuse, 14-year-old, playing basketball around 6 p.m. last Friday when he experienced severe chest pain, shortness of breath, chest pressure, and had a syncopal event that lasted several minutes. Of course, EMS was called, and he was transported to the nearest ER. And upon evaluation, he was noted to be hypotensive, hypoxemic. He was started on oxygen and then progressed to BiPAP, received IV bolus of fluid, and he was given a dose of aspirin. This is his EKG with new onset right bundle branch block. He has tachycardia, and this is totally different from an EKG that he had almost a year prior to those symptoms. His COVID was negative, his troponin was elevated, chest x-ray showed pulmonary edema, he had RALs on auscultation, and he came to our hospital, and this is how his echocardiogram looked like. This is short axis view, and you can see that the left lateral wall and the posterior wall of his left ventricle is not doing anything at all. We thought that this was an acute coronary event. The coronaries could not be imaged very well because he was hyperventilating and didn't have good windows. So he was sent to our collaborating adult hospital with the plan to have his left coronary artery reperfused. Unfortunately, our adult colleagues could not catheterize his left coronary, who had an intramural pulse and was coming from the right sinus of valva. And during his catheterization, he arrested, had CPR, and ended up on ECMO. And this is how his left ventricle looks on a 4-chamber view. You can see that he has some mitral regurgitation. And this is his coronary imaging on ECMO, and you can see the thin left coronary again coming from the right, and the acceleration in the interluminal acceleration and the susceptibility of this vessel to exercise that resulted in his huge myocardial infarction. This is a modified inverse view of this coronary. And again, you can see it here. This is the PA. This is the left. This is the right. And you can see that this coronary has an intramural course and goes to the left AV groove. And here again, you can see the flow acceleration of the coronary. So the diagnosis, in a sense, is not easy, but we can coin it one way or another. Transthoracic echocardiography is the first imaging modality. It's the one that will pick up the incidental cases. In the literature, there's variable agreement between transthoracic echoes and surgical findings, but there are papers, and especially the latest ones, that have a 95% agreement of echo and surgical findings. Of course, there are advanced imaging modalities, a computed CTA, a gated CTA, or a CMR. The CTA will give us a lot of information. It will give us the origin of the coronary, respect to the opposite sinus, valve commissures, and level of origin. It can give us the ostial morphology. You can see here a slit-like ostium of the right coronary that's coming from the left, and can give us the extension of the intramural course. Anything that is above 5 millimeters is considered significant. And of course, if there's intramyocardial course, it can show us as well. The cardiac MRI is an emerging technique that has very good results as far as imaging coronaries, especially in older children and adolescents. It will give us the origin, it will give us the commissures and the relations to the origin of the vessel. It will give us the level of the origin. And of course, it will characterize the course interarterial, intramural, intramyocardial. And most importantly, it will give us functional data, assessment of ventricular function, myocardial perfusion abnormalities, regional wall motion abnormalities at rest or with pharmacological stress, and myocardial viability and scarring, which in a lot of kids with sudden cardiac events, is present when you do MRI on them. The nuclear perfusion imaging is something that people move away from just because there's a high false positive and false negative rate. There's a lot of artifact, there's decreased spatial resolution, and of course for kids, there's use of ionizing radiation. Stress EMR with dobutamine or atropine is feasible in children, and more centers get comfortable with it, are doing it, especially centers that have coronary anomaly programs. Exercise tests is a traditional test that is used to evaluate patients for evidence of ischemia or ventricular arrhythmias. But unfortunately, there are mixed data regarding its validity. Texas Children's Hospital, one of the pioneers in studying this disease, reports only a 5 to 8% positivity in patients who undergo surgery. But nonetheless, even if a negative exercise stress doesn't mean a lot, a positive one does. So it is always included in the evaluation. Cardiac catheterization is used frequently with intravascular ultrasound just to assess the degree of coronary stenosis and the length of an intramural segment. Most of the times in older children, and in some patients, it can assess the fractional flow reserve and in combination with pharmacological stress. Now, the challenge of the diagnosis is the risk stratification of those patients. We have to identify myocardial ischemia, but it's not always easy. We have to identify who is at risk for sudden cardiac events. That's not easy either. And of course, we have to know what is the impact of surgical intervention on outcome, especially when we don't have symptoms and we have incidental findings. That might be a help with a standardized approach to evaluation and management. So most of the centers, especially the ones that have programs, coronary abnormality programs, they start with a transthoracic echo. They advance with an ECG-gated CTA in order to characterize the type of the anomalous or aortic origin of a coronary artery, the presence and the length of the intramural course, the definition of the ostial location, the relation to commissure and sinus. And of course, myocardial functional studies, the stress exercise stress test, stress echo or stress CMR, wherever they are available and there is experience. And invasive assessment of coronary flow, the FFR during cardiac cath, selective angiography with administration of adenosine or dobutamine, or the alcoholics are better with that, and IVUS, of course. Now, the clinical decision-making, that's a tough one too. There are a lot of unknowns. The risk of sudden death, as I said, is not known. And we cannot pinpoint what are the circumstances that are leading to the sudden event. Usually exertion, but not exclusively. A lot of, there's the notion that the anomalous origin of the right coronary is not as dangerous as the left, but still we have sudden cardiac events in abnormal aortic origin of the right coronary. And of course, as I mentioned before, there's lack of long-term data on outcomes in both repaired and non-repaired patients. Now, the surgical management, this is not my area of expertise, but there are two methods that surgical repairs that are popular. The one is the one that is more applicable or more applied is the unroofing of the intramural course of the coronary. And you can see it up here on the in this diagram. This is the intramural coronary, so the surgeon kind of like opens that up, but the ostium of the abnormal coronary remains at the wrong sinus, and the commissure sometimes of the aortic valve is exposed or kind of like messed a little bit, so you end up with aortic insufficiency. The other method is translocation and reimplantation, and that is something that is getting more favorable. You transect the coronary at the exit from the intramural course, and you relocate it in the sinus where it's supposed to be coming from. And as you can see here, the same respective diagram. Are the results always good? Not always. Here's another patient that we've seen in 2016, had a syncopal event during exercise, and you can see here the NPR of his CTA, and you can see the long intramural segment of his coronary, and this is the left coronary artery, and this is in 2017 when he presented with SVT. He had AVNRT that was ablated, but he complained of chest pain, and repeat CTA showed some kind of restenosis of the ostium of his coronary, and you can see here in his cath that his left coronary entrance is stenotic. And FFR was done, and it was 0.89, which is considered normal for, not normal exactly, but not indicated for intervention. And this is his coronary in 2018, and you can see there's some tissue here causing some stenosis. And in an effort to explain to the parents what is going on, this is the 3D reconstruction, a 3D model, and you can see that a 2mm probe can go very freely in the right coronary ostium, but not as easy in the left, which is stenotic. So the outcomes are not very well known because there have been small series from certain centers. And a couple of years ago, the Congenital Heart Surgeon Society published the results that were very enlightening and kind of like give us another perspective for the disease. So 45 centers were involved with a median follow-up of 2.8 years and an almost 20-year enrollment of patients that were less than 30 years old. Of the almost 700 patients, almost 457% of them were surgical patients with primary repair, then roofing of the abnormal coronary, and 26% of them had commissural manipulation. 13 of those patients had 15 coronary-related reoperations. And on the 358 that had pre- and post-op aortic insufficiency evaluation, 8% developed new mild or greater than mild aortic insufficiency, and 7% developed new moderate or greater than moderate insufficiency. Almost 10% of them have aortic insufficiency, which is, as we know, an evolved process. And of the 350 that had ejection fraction evaluation, 2% developed new abnormal EF, 50%, less than 50%. And the ones, a good thing that was from the ones that had preoperative ischemia, almost 80% had no ischemia post-op. A lot of them, though, continued to have chest pain. 4 died post-operatively, 2 of them were symptomatic, 1 asymptomatic and 1 in extremis. So the composite surgical adverse event rates were between 7 to 13% in the entire cohort. This is something that we cannot ignore. So management, clinical versus surgical, we have to discuss with the family and make them part of the decision-making process. Patients with high-risk anatomy, this is a no-brainer, will have surgical intervention. Patients with anatomy that is deemed as suitable for surgical intervention, such as like a conal artery that is intramyocardial crossing the conal septum, will have exercise restriction, prescription of beta blocker therapy. And parents, the patients need to have continued follow-up regardless of surgical or medical therapy. Exercise restrictions need to be applied to patients that await surgical interventions, applied 3 months after surgery. High-risk lesions, patients that refuse surgical intervention should be restricted from exercise, and those deemed unsuitable to the current surgical strategies. And the patients that are deemed to have low-risk lesions are allowed unrestricted exercise activities. And actually, this is the trend now to let them exercise because even if you tell them not to play on the high school team, they'll go and play with their friends and they'll have the event there. When they're at school, there might be a defibrillator that can help them. This is the coronary anomalies program, from Texas Children's. This is their algorithm of what they do and when they have patients. And it's pretty much the things that I went through already. And for the sake of saving some time, I'm gonna proceed to my last slide, the conclusions. Presentation anatomy of patients with anomalous aortic origin of the coronary artery are variable. The best management strategy is probably the one that is tailored to each patient. The decision to recommend operation should be made after detailed discussion with the patient and the parents, and all potential anatomic culprits should be addressed when surgical management is undertaken. Unfortunately, the question, do the risk of sudden cardiac event outweigh the risk of surgery, has not been answered yet. But I guess if we kind of like combine our efforts and get our results together in registries, we'll have an answer sooner rather than later. Thank you.
Maria, I would like to congratulate you for a very nice presentation and say that it is a great pleasure to see you again after some time. I'm happy that you're thriving, and I'm very happy that you gave a very nice presentation. I'll come to a couple of comments and the questions before I turn the speaker over to my co-chairs. First, surgically, I'd like to make the following comment. The risk of ischemia and sudden death comes obviously from anatomy. Now, the elements of anatomy that are important are the presence or absence of a slit-like orifice, the presence or absence of an intramural segment, and the course of the artery between the aorta and the pulmonary artery. And you're absolutely right. I love your concluding slide that any contemplated operation should address the mechanism of ischemia. In this regard, it is very important for us to know whether there is actually an intramural segment. I'm not sure if you can always tell based on your imaging. I'd like you to tell me that. The reason this is very important is that the mainstay of surgical therapy is unroofing, which abolishes the slit-like orifice if it exists, and it moves the functional orifice and therefore the course of the artery from between the two great vessels. So if there is no intramural segment, this option is not there. And the only option would be translocation. And translocation is not possible in situations where we have basically the two orifices so close together between I'm talking about the right main and the left main. If the orifices are very close, it's like a single coronary, you cannot move it around because then you would stretch one or the other. This is a situation where we frequently have in arterial switch operation if we have anomalous coronaries. So in this situation, a surgical option would be to actually move the pulmonary artery away. Okay, so it is very important for us to know if there is an intramural segment or not. So that's sort of a general comment. The specific question is, in your practice, if you have a child and the family come to you, it was discovered that they have an anomalous left coronary artery originating from the right coronary sinus. It was discovered because the child wanted to play college basketball. And child is entirely asymptomatic. You do a stress test, an ischemia test, everything is negative. Do you allow this child to take part in athletics, or do you recommend surgical revision of the anatomy?
Now, those are the patients that give the cardiologist chest pain, right? So did you say that we have intramural course or not? And
yes, typical case, intramural course.
Intramural course and a slit-like ostium or not? Imagers are very good, so they can tell you that. By CT or MRI, you can have the answer for that.
Sure.
There are a couple of things.
Asymptomatic.
Asymptomatic. Well, this is the tough ones, right? You have to see this is a right dominant system or a left dominant system.
The balance system. It's a balance.
You're making it more okay. So
it's like an examination.
That's fine. That's life. That's life. That's my clinic, right? No. Well, the trend now is not to operate if people are asymptomatic and they have no signs of ischemia. Well, I shouldn't be so dogmatic about it, but you have to sit down with the parents. You have to tell them the pros and cons. You have to tell them that this is an unknown, and it's 50-50 on the families. A lot of them cannot deal with the stress of having that, and they will ask for an operation. So you offer the surgery, you don't recommend it.
The practical matter is when the family requests a doctor's certificate because the team requires a certificate to allow the child to play. The child wants to play, and the team requests authorization from the physician. This is the clinical situation that we're in.
Yes, if I sit down with the parents and explain everything, I will give this patient a certificate.
Thank you very much, Maria. Just to also let you know that the European Congenital Heart Surgeons Association is also running a long-term registry study of patients with Aorta, and we hope that this registry, along with the other registries in the US, will provide answers to some of these very, very important and difficult clinical questions. Thank you.
We all hope so. Micah Julie is on the panel. Hi.
Ευχαριστούμε πάρα πολύ την κυρία Kiaffa και...
Να ρωτήσω και εγώ, κύριε Βλάχο, αν την κυρία Kiaffa, εάν έχει μπει κλινική υποψία, αλλά δεν είμαστε σίγουροι από το υπερηχογράφημα και θα θέλαμε να κάνουμε μία μόνο εξέταση επιπλέον για να κάνουμε τη διάγνωση. Ποια θα προτιμούσατε και γιατί?
Ναι, εξαρτάται από την ηλικία του ασθενούς. Και βέβαια και από τα διαγνωστικά τεστ που έχουμε στη διάθεσή μας. Αν είναι κάποιο παιδί που είναι πάνω από 7 ετών, οπότε δεν χρειάζεται γενική αναισθησία για να κάνει μαγνητική, θα έκανα μαγνητική καρδιάς, γιατί θα έχω και τα ανατομικά και τα λειτουργικά στοιχεία που χρειάζομαι για να κάνω το risk stratification για τον άρρωστο. Εάν όχι, θα έκανα αξονική τομογραφία.
Ευχαριστώ.
Ευχαριστήσουμε λοιπόν την κυρία Kiaffa για την καταπληκτική ομιλία και θα ήθελα εδώ να τονίσω και προς τους καρδιολόγους που αναγκαστικά βλέπουν τα παιδιά και κάνουν αυτόν τον υπέρηχο για να δώσουν το χαρτί ότι ό,τι μοιάζει με στεφανιαίο δεν είναι πάντοτε στεφανιαίο. Χρειάζεται πολύ καλή εκπαίδευση στον υπέρηχο και σίγουρα κάποια θα χαθούν. Ευχαριστούμε πάρα πολύ.